All right. Well, good morning, everybody. It's Happy New Year. It's 2026. This is our monthly ICOS seminar series. And our first guest of 2026 is Dr. Lucie Turcotte. And Lucie, guess what? I'm going to introduce you without looking at your CV. So just to let you know that I know Lucie so very well. And you will correct me if I say anything wrong, okay? So Lucie started her formal undergrad and then beyond education, starting at Notre Dame. Was that a good experience, Lucie?
It was. It was a pretty good spot.
Okay. And my um, experience with Notre Dame is only through West Wing. Um, for those of you who watched West Wing will know that Notre Dame was a favorite thing for them, right? Okay. We are going now to where Lucie goes and does an MD at the University of Minnesota, and then takes a quick out of the state experience to do her residency in Seattle. But says, no, I want to be back in Minnesota again, and does her fellowship in pediatric oncology in Minnesota. But you did do your MPH in child and women's health in along with your MD. So what was that about?
I actually did it before, started it before. I
Uh-huh.
wasn't sure I wanted to go to medical school. I thought I might just want to work in the nonprofit world and then decided I liked people. So
Okay.
decided to
All
go to med
right.
school.
Okay. So fellowship in Minnesota, and then she was quickly absorbed into the faculty in Minnesota, and that's when she did her MSc or medical and sorry, master's in how do you call it? It's
In
not an
clinical
MPH.
research. Yep.
Yes. And that was part of your being a junior faculty there.
Yeah, it was actually started during my fellowship, and then my mentor at the time, Julie Ross, passed away, so I didn't end up defending it until during my junior faculty time.
Okay. All right. Um, but has risen through the ranks really quickly. She's an associate professor in pediatric oncology in the Department of Pediatrics at the University of Minnesota. She's also the division director of pediatric hemonc. She's also in charge of all the survivorship programs there, including the for the cancer center, and was recently, in terms of national recognition, awarded the ASPO Survivorship Queen Award, um, which happened recently, and has published close to 100 papers, is funded for health equities research for those of you who are here and working on health equities, which is pretty much everyone. Um, and you managed to keep that award through all these turbulent times, huh, Lucie?
Yeah, it took we magically didn't use one of any of the words on the magical list. So our latest grant made it through after several rounds of scrutiny and several months of delay. So we were
Yeah.
very fortunate.
Yeah, and Lucy's published extensively and made some really strong observations, very insightful in second cancers, in particular because she heads the second cancer working group for the childhood cancer survivor study. So, Lucy, without further ado, I don't want to spend all of the time having this conversation with you. Here you go. I'm handing the podium over to you, okay?
Sounds good. Let me make sure I can share this okay. Mhm. All right, does that look okay?
Yes, looks great.
All right, I'm gonna just hide all of you so I can see everything. All right. Well, thank you so much for the opportunity to speak to your group today. It's always a struggle to decide what to talk about in a group like this with so many experts in so many different areas. And I know that many of you have a lot of expertise in subsequent cancers. So I'm hoping that I can bring a little bit of a fresh perspective to some of the work that I'm doing. And I thought it would be fun to talk a little bit about how subsequent cancer research has evolved over the last several years using some of the work that I've led as examples. But now that Smita mentioned some of the health equity work, I'm questioning if I should have decided to talk about some of that instead. I have no disclosures to report today.
We'll call you back for the health equities.
Perfect. Well, if anyone's going to be at Tandem in a couple of weeks, I'll be speaking at the pediatric day on some of that work. So anyway, it's a very cold day in Minnesota. I don't usually complain about not having to travel, but in many ways, it's been cold here in Minnesota lately. And I was looking on my app this morning and saw that the feels like or the wind chill here is not expected to get above 3 degrees today. And it looks like it's a little bit nicer and toastier in Birmingham. So I hope you're all enjoying the heat wave there. Today, I'm going to be talking a little bit about basic epidemiology and treatment-related risk factors for subsequent neoplasms among survivors of childhood cancer. I'll review some of the recent research on novel risk factors for subsequent neoplasms, discuss some of the clinical risk prediction models for subsequent neoplasms, and then share some of the recent outcomes data that we've had for subsequent neoplasms, specifically in subsequent breast cancer. So for all of you, whatever your role is in childhood cancer, and for some of you, it might not be anything at all, but whether it's in researching new therapies, providing care to on-treatment patients, or in survivorship and outcomes research and clinical care, I think we can all agree that progress that has been made in survival among our pediatric cancer patients is quite impressive. Such that now 85% of children who are diagnosed with cancer can expect to be alive 5 years after being diagnosed. And what this means is that we have a rapidly growing number of survivors. And as the number of survivors grows, these survivors age, and we're seeing that the majority of them are faced with a number of late effects, many of which are severe or life-threatening. And most of these late effects, as most of you recognize, are related to the treatments that were used for their childhood cancer therapies. These chronic conditions and these late effects matter because they impact long-term survival and late mortality in our childhood cancer survivors. Here on the left, you can see that survival among U.S. males and females in the general population, as shown in the top solid and hashed lines, compared to survival over time among childhood cancer survivors, shows a significant disparity. And the figure is a little bit deceiving since the y-axis only goes down to a survival probability of about 75%. But you can see that by 30 years from cancer diagnosis, there's a pronounced survival gap between survivors and the general population. And although 30 years can sound like a long time, even our oldest survivors are not even 50 years old by that time point. And I think it's notable that even as survivors age beyond 50 years, the gap in mortality persists. On the right is a figure from an analysis that was published last year in the Journal of Clinical Oncology examining health outcomes among aging survivors. And as you can see, beyond 50 years, survivors continue to have a higher mortality risk compared to the general population. When we look at causes for mortality, you can see that although recurrence or disease progression is the most important cause for mortality early on, by 15 to 20 years from childhood cancer diagnosis, the slope of the subsequent neoplasm curve that's shown here in red overtakes it and accelerates with time, showing that as survivors age, subsequent neoplasms become an important cause of mortality. And similar to the last slide, when causes of death are considered beyond 50 years of age, you can see that subsequent malignancies continue to be the leading cause of death, as shown by the light green curve here, in case some of you can't maybe see the colors as well. Although you can see in the aging survivors that cardiovascular disease as causes of death are not far behind subsequent cancers. I think it's interesting that the recognition of subsequent neoplasms or secondary cancers is not new. These two reports that dated back to 1965 from Roswell Park and 1968 from Boston Children's reviewed reports of secondary cancers based on autopsy reports and radiation therapy records. However, at the time that they were published, etiology and incidence of subsequent cancers was not well understood. And I think just to back up a little bit and talk about some of the subsequent neoplasm definitions, over time, the description of these events has become more standardized. And when we talk about second cancers or subsequent neoplasms, it's important to define them so we're all on the same page. In most subsequent neoplasm research, secondary cancers are divided into three main categories. Benign meningiomas, as you can see here, these are non-malignant neoplasms in the brain. Oops. That typically arise after cranial radiation exposure. And then there's also non-melanoma skin cancers, as you can see up in the upper left-hand corner. These are invasive cancers, but include things like basal cell carcinomas and squamous cell carcinomas. They're not typically captured in cancer registries, so we separate them from other invasive or malignant neoplasms. And then there's the invasive or malignant neoplasms, as shown in the bottom, things like thyroid cancers, sarcomas, and breast cancers. And these are typically invasive cancers that are defined based on ICD-10 behavior codes and limited to those with malignant behavior. We often include pre-malignant or in situ conditions in this group as well. So behavior codes that are less, but often have the potential to behave similarly. With all these groups, it's important to note that these are not recurrences of the primary childhood cancer. These are new primary neoplasms that often develop as a result, at least in part, of previous cancer therapies, along with potentially cancer predisposition. Next, I want to highlight my research over time on subsequent neoplasms, and a lot of this research comes from the Childhood Cancer Survivor Study, or CCSS. And although I know this study is familiar to many of you, I wanted to highlight a few basic study characteristics just to orient you to some of this work. So the CCSS is a multi-institutional longitudinal cohort study that includes at least 5-year survivors of childhood cancer who were diagnosed between 1970 and 1999. Cohort currently includes about 23,000 survivors. One of the benefits of this cohort is that it includes comprehensive treatment data that's been abstracted at their primary treatment site up through 5 years from diagnosis. And then every couple of years, the participants receive questionnaires where they're able to self-report a number of different conditions, but particularly including things like late effects, so health conditions like chronic health conditions, and they also self-report subsequent neoplasms. And although similar to chronic health conditions, subsequent neoplasms are initially self-reported, the CCSS has taken a more rigorous approach to validating the subsequent neoplasms. So once these conditions have been reported, the CCSS Coordinating Center at St. Jude obtains pathology reports or other medical records. And then a pathologist or oncologist reviews them to validate the reported condition, which is where I came into all of this. So although I mentioned a few slides ago, the CCSS now includes over 23,000 survivors and spans diagnosis years from 1970 to 1999. When I first became involved in the study in 2012, things looked a little bit different. At that point, the study included just over 14,000 survivors who were diagnosed between 1970 and 1986. And at that point, there were about 2,400 validated subsequent neoplasms in the study, along with several new neoplasms that had not been part of the frozen data set yet. Important publications at that point included descriptions of secondary GI cancers, sarcomas, basal cell carcinomas, and thyroid cancers. And at this point, I was a third-year pediatric hematology oncology fellow, as Smita mentioned, at the University of Minnesota, and I was really interested in getting involved in survivorship research. My mentor, Joe Neglia, mentioned to me early in that year that the CCSS was hoping to find someone to come to St. Jude to re-review and provide localization on all of the subsequent neoplasm data, so about the 2,400 plus conditions that had previously been reported, so that they could then merge the data set with a GWAS data set being created in collaboration with investigators from the NCI. I naively had no idea what I was getting into, and of course said yes at that point, and went to spend a few months in Memphis. At that point, I had a 2-year-old daughter that joined me for part of the time. That's her in the upper right-hand corner. She was pretending to fish when we were hanging out at our apartment on Mud Island. But I spent about 12 hours a day for a couple months looking at that lovely silver pyramid in the lower right-hand corner. And it really has ended up being a huge part of my career based on that simple yes as a second-year fellow. So watch out, trainees. But it was a really long few months. I learned a lot about second cancers and really developed a strong interest in this area. And at the time, the most current broad subsequent cancer data that had been published was from Deb Friedman and JNCI in 2010. And it showed that among the 14,000 survivors, 1,400 had developed about 2,400 subsequent cancers. And this resulted in overall 30-year cumulative incidence of subsequent neoplasms of 20% and a 30-year subsequent malignancy incidence of 8%. And as you can see, for each of the subsequent neoplasm subgroups, incidence was higher among survivors previously treated with radiation, as shown by the curves labeled with RT and circled in red. Follow-up work around this time showed that different subsequent neoplasm types demonstrated specific radiation dose response relationships, as shown in the figure on the left. And the figure on the right really just helps to contextualize the risk of subsequent neoplasms associated with therapeutic radiation exposure. And I'd like to show this because I think it's important for people to recognize that this risk really is not trivial. This figure comes from a paper from Haya Moskowitz examining chest radiation exposure as a risk factor for subsequent breast cancer. And what we're seeing here is breast cancer cumulative incidence based on attained age, as shown on the x-axis. Radiation-exposed Hodgkin lymphoma survivors are represented by the top darker blue curve, and other radiation-exposed childhood cancer survivors are represented by the yellow curve, just a few below. What's particularly interesting here is that the gray and red curves represent women with BRCA1 and BRCA2 gene mutations. As we know, strong predictors of developing breast cancer in women. This is a powerful demonstration of the level of risk these young female survivors face after exposure to chest radiation. These are only a few examples of the important descriptive work that was being done, but studies like these really help set the stage for the next direction of subsequent cancer research. So as I mentioned, an additional 10,000 survivors were added around the time that I was getting involved in the CCSS. And those included individuals diagnosed between 1987 and 1989. At that point, the cohort was enriched for non-white individuals through inclusion of 4 different institutions, and it really enhanced the ability to address the effects of treatment changes over time. A sentinel study from the newly expanded cohort was published in the New England Journal in 2016, and it examined whether late mortality was changing over time for survivors. And as is shown here, Dr. Armstrong had shown that survivors diagnosed in the 1990s experienced a significant decrease in all-cause cumulative mortality. And here you can see the cumulative incidence of mortality from multiple different causes at 15 years. And based on the year that the childhood cancer patient was diagnosed. And they showed that specifically deaths from subsequent neoplasms had decreased over time, as had deaths from cardiac and pulmonary causes. With that late mortality decrease among survivors in more recent treatment eras, and specifically subsequent cancer-associated deaths decreasing, it led us to question whether overall subsequent neoplasm incidence was also decreasing and contributing to the reduced subsequent malignancy-specific mortality, or whether survivors were experiencing increased survival after developing a subsequent neoplasm. So we explored this and reported our findings in this 2017 report in JAMA. So when we examined temporal changes in treatment exposures for survivors that were treated in the 1970s, 1980s, and 1990s, we saw that the proportion of survivors treated with therapeutic radiation decreased from nearly 80% in the 1970s to approximately 40% for survivors diagnosed in the 1990s, as shown by this blue curve here. Over that same time frame, the proportion of survivors treated with alkylating agents and epipedophila toxins increased, as shown by the yellow and green lines in the figure on the left. When we looked at chemotherapy cumulative doses by decade, as shown on the right, we saw that although the proportion of survivors receiving alkylating agents increased, the cumulative doses received actually decreased over time. And for epipedophila toxins, cumulative doses initially increased from the 1970s to 1980s and then decreased in the 1990s. When we looked at cumulative incidence of subsequent malignancies based on decade of childhood cancer diagnosis, the x-axis showing time from childhood cancer diagnosis and the y-axis showing cumulative incidence, you can see that the 15-year cumulative incidence was significantly decreased over time, such that at 15 years in the 1970s, the cumulative incidence at 15 years was 2.3%, and by the 1990s was 1.6%, which represented a significant decrease. We then considered standardized incidence ratios, or SIRs, which are a ratio of the observed number of subsequent malignancies among survivors divided by the expected number based on comparable SEER data matched on age, sex, race, and year of diagnosis. We considered attained age, as shown on the x-axis, as well as decade of childhood cancer diagnosis, as shown by the circles, triangles, and squares. And as you can see, the SIRs decreased over time for survivors with attained ages of 20 to 29 and 30 to 39. We next wanted to understand if specific treatment variables might be associated with reductions in subsequent neoplasms that we were seeing in more contemporary treatment decades. So using multivariable models, initially not adjusting for any treatments, as shown by the top row, we saw significant decreases in all types of subsequent neoplasms over time. We then adjusted for different treatments and found specifically that when we adjusted for maximum radiation dose, the most strongly attenuated the observed decline. This was the first paper to demonstrate that decreased use of radiation over time had resulted in decreased rates of subsequent malignancies. So based on these findings, that we were using less radiation and that the risk for subsequent neoplasms was decreasing, we wanted to understand the role of chemotherapy as a risk factor for subsequent neoplasms, particularly in the setting of survivors who are not treated with radiation. So this work was published in 2019 in the Journal of Clinical Oncology, and we included just over 7,400 survivors who were exposed to chemotherapy but no radiation. Among this group, there were 229 subsequent malignancies that were confirmed among 206 survivors. The most common types of subsequent malignancies that we observed were malignancies of the breast, thyroid, melanomas, as well as soft tissue sarcomas, and you can see their associated SIRs there. We then looked at the cumulative incidence at an attained age of 45 years based on the childhood cancer treatments. So you can see that the red line represents individuals who are treated with chemotherapy and radiation. By 45 years of age, their cumulative incidence of a subsequent malignancy was 13.7%. The individuals who were treated with radiation and no chemotherapy, I'm looking and should be blue. This looks a little dark, maybe navy. Radiation and no chemotherapy had a cumulative incidence of 13.3. Our survivors who were treated with chemotherapy and no radiation had a cumulative incidence of 7.4% as compared to those who received no chemo and no radiation. And this was significantly higher cumulative incidence among the chemo and no radiation group, although notably much lower than those who were treated with radiation. When we looked at multivariable models that included specific chemotherapy classes and cumulative doses, and were adjusted for sex, age at childhood cancer diagnosis, and treatment era, we found that exposure to high-dose alkylating agents and high cumulative platinating agents were associated with increased rates of subsequent cancers. And we looked specifically at the dose-response relationship between alkylating agent cumulative dose and subsequent malignancy relative rates, and we saw a linear dose response as shown in the figure on the right. And I think it's important to mention with this particular study, it's something that often comes up. We did not have at the time any genetic predisposition data with this study, which I suspect would have been quite interesting, but was a limitation of these data. I also wanted to review subsequent cancers among aging survivors. So at the time when we did this study, most of the studies of survivors included individuals that had not yet aged beyond 40 years of age. And it was previously questioned whether these treatment-related risk factors would have sustained effects over time as survivors aged into their fifth and sixth decades of life. So this was actually the first subsequent cancer analysis that I did with CCS data. And at the time that this was done, there were only about 3,100 survivors with an attained age of 40 years or more. And you can see that among that group, about 470 had had some type of subsequent neoplasm before age 40, but 2,700 of them had not. So the distribution of subsequent cancer types is shown in the table on the right. And interestingly, it was not particularly different from the distribution that we were seeing of subsequent cancers among younger survivors, with breast cancers being the most common type of cancer. And these were all neoplasms that were occurring after 40 years of age. And this curve shows the cumulative incidence of all types of subsequent neoplasms, including non-melanoma skin cancers and meningiomas, as shown by the gray curve. So by age 55, with 40 years as kind of the zero time point, looking at only neoplasms occurring after age 40. By age 55, nearly 35% of this group had experienced some type of subsequent neoplasm. And when we specifically were interested in malignant types of neoplasms, that is shown by the red line, and that was about 16% of the group at age 55. And as you can see, that these events continued to increase with increasing attained age. We know that the rates of cancers in the general population also climb rapidly in this age group, particularly with certain types of cancers. So the comparison of observed to expected events, or SIRs, was particularly important in the older age group to understand if the cumulative incidence curves we were seeing mirror what would be happening in the general population, or were unique to the survivor group. And we saw that increased risk compared to the general population for any subsequent malignancy was about fourfold higher than the general population. And then you can see that for these types of subsequent cancers, including breast, renal, soft tissue sarcoma, and thyroid cancer, they were significantly higher risk compared to the general population. Interestingly, I mentioned Dr. Bandari's report on aging survivors that was just published in JCO this past year, where she focused on survivors that were older than 50 years of age. And although those SIRs continue to gradually decrease with age, they continue to observe increased risk for multiple cancer types compared to the general population, which were quite similar to what we observed here 10 years earlier. One of the other things that I thought was interesting, as part of a review of subsequent cancers that we published in 2018, we performed an analysis comparing the risk of subsequent malignancies across large childhood cancer survivor cohorts in the United States and Europe. And this included the CCSS, as well as the British Childhood Cancer Survivor Study, a collaborative effort from the Nordic countries, and then the Dutch Childhood Cancer or Childhood Oncology Group Long-Term Effects After Childhood Cancer Study. And interestingly, as you can see, the SIRs, despite different ways of ascertaining the data, were similar across different cohorts, and risk remained elevated even beyond 50 years of age for all of the groups, when the expected number of malignancies in the general population is starting to climb. So these findings were not unique to survivors treated in the United States. So over time, it's become apparent that to keep our research relevant and to continue moving the the dial on improving outcomes for childhood cancer survivors, we need to do more than simply report numbers and risk factors, which I think overall has been done fairly comprehensively at this point. So while we've continued to publish some of the important analyses on individual types of subsequent cancers and their risk factors, we've also really started to think about other ways that we can identify survivors at risk. Within the subsequent malignancy working group, we've put out some really excellent work over the last 5 years. And although I don't have time to highlight everything, hopefully with a few of the studies that I will focus on that I've been involved in, you'll see some of the interesting directions that the field is moving in. So I wanted to highlight this study that was led by Dr. Cindy Im, a colleague and close collaborator of mine from the University of Minnesota, along with Dr. Sheriff Felden, who is on the call today from University of Alabama at Birmingham. They wanted to understand how we could incorporate genetic susceptibility information to improve late effect risk prediction. So over the last 5 years, there's been increasing attention to the potential impact of polygenic risk prediction. So polygenic risk scores, or PRS, are single measures of genetic risk that use results from genome-wide association studies. And since the majority of heritability for most common diseases is not captured by a small set of rare mutations, PRS are intriguing because they capture common genetic variation risk across the entire genome. However, it's not been clear how well general population PRS performs when used in childhood cancer survivors. So this study sought to quantify the role of genetic susceptibility in chemotherapy-associated SMN risk among survivors of European and African genetic ancestry from the Childhood Cancer Survivor Study, as well as the St. Jude Lifetime cohort. They used an externally validated 179 variant PRS associated with pleiotropic adult cancer risk from the UK Biobank study and computed that for each of the survivors within the cohort. This included 9,895 survivors of European ancestry and 718 of African genetic ancestry. Figure on the left shows subsequent malignancy risk by PRS quintile among survivors of European ancestry. And as you can see, it stratifies survivors treated with any radiation therapy on the left and those not treated with radiation on the right. The colored vertical bars represent PRS quintile scores, with the highest quintile shown on the far right of each group and the lowest quintile as the reference group for analysis. 53% of European ancestry survivors received therapeutic radiation, and among them, they developed 1,100 subsequent cancers. This left 4,322 non-irradiated survivors that developed 259 subsequent malignancies. Interestingly, as you can see in the radiated group, there was minimal association between PRS quintile and subsequent malignancy risk. However, when non-irradiated survivors were considered, there was a strong and significant association between PRS quintile and subsequent malignancy risk. Associations were also seen between PRS quintile and subsequent malignancy risk among non-irradiated European ancestry survivors for specific chemotherapy group exposures, including alkylating agents, anthracyclines, epipodophila toxins, and platinums, as shown in the figure on the right. When comparing non-irradiated survivors in the top versus bottom PRS quintiles who were exposed to different chemotherapy subgroups, the 30-year cumulative incidence of subsequent malignancies was significantly different between the extreme PRS quintiles for each chemotherapy group. Cumulative incidence curve for epipodophila toxins is shown on the left. Improvements in prediction attributable to the PRS were greatest for the epipodophila toxin exposed survivors, resulting in an increase in area under the curve, or AUC, from 0.63 to 0.71. And when interactions were explored between PRS and specific treatment exposures, there was a significant PRS treatment interaction for epipodophila toxin exposed survivors of European ancestry. And despite overall small numbers, this PRS also significantly modified epipodophila toxin related SMN risk among non-irradiated survivors of African ancestry. Another recent analysis that I'd like to highlight looked beyond traditional treatment exposures when investigating subsequent cancer risk, and looked specifically at body mass index and physical activity. And this was published this spring in JAMA Oncology and was led by Dr. Linat Jaffe from Northwell Health. For this analysis, we looked specifically at time-varying BMI, or measure accounting for BMI from the time of CCSS cohort entry through the last BMI, or body mass index, reported prior to subsequent cancer development, as well as maximum physical activity level from prior to the development of a subsequent neoplasm. And we found that these were associated with subsequent neoplasm risk. And just to highlight a few key findings, you can see that obese BMI was associated with increased solid organ subsequent cancer risk. And when we looked at specific types of subsequent neoplasms, we saw an increased risk for thyroid carcinoma and meningioma. Similarly, when we looked at physical activity levels, as shown in the bottom figure, we saw that survivors with high amounts of physical activity had decreased levels of decreased risk for subsequent neoplasms. And when we looked specifically at the types of subsequent neoplasms that had reduced risk, we saw again that thyroid cancers and meningiomas had reduced risk associated with high levels of physical activity. So it's somewhat interesting and a little bit unique from what we'd hypothesized. We were anticipating increased risk for known obesity-associated malignancies, including postmenopausal breast cancer and colorectal cancer, which we did not observe in this analysis, which I suspect is just because of the large association with treatment-associated risk factors. However, both meningioma and thyroid cancers are known to be associated with obesity in the general population as well. Although we were not able to look at cumulative incidence curves with the time-varying BMI measure, the cumulative incidence curves that were based on physical activity levels were actually fairly impressive. The upper left corner shows any type of subsequent neoplasm, and you can see that the lowest physical activity level, as shown, this kind of blackish brown curve compared to the highest physical activity level shown by this tan curve, was significantly different. And again, then when we're looking at, saw similar findings for solid organ neoplasms of the central nervous system, as well as skin cancers. I think these findings were really interesting and suggest that both BMI and physical activity could be considered in future subsequent cancer prevention research. One of the areas of subsequent cancer research that I've been particularly excited about over the last few years has been enhancing our personalization or risk prediction to better understand which survivors are at highest risk for developing certain cancers, and then trying to understand how we can most efficiently screen these at-risk individuals. So first, let's talk about the implications of improving late effects clinical risk stratification using current screening guidelines for subsequent breast cancer. So I currently am serving as the chair of the COG Long-Term Follow-Up Guidelines SMN and Cancer Screening Task Force. And the current COG Long-Term Follow-Up Guidelines for survivors treated with any radiation therapy to the chest recommends a yearly mammogram and breast MRI starting at age 25 or 8 years after radiation for childhood cancer, so whichever one of those occurs later. However, the burden of breast cancer screening among survivors, which begins during individuals in their 20s or early 30s, is not trivial. This includes time and financial toxicities, and also includes multiple opportunities for false positives and added stress and anxiety for survivors and their families. I think also interestingly, when you look in the guideline, there's a section labeled additional info, which reads, consider patient and cancer treatment factors, premorbid, comorbid health conditions, and health behaviors that may increase risk, which for a lot of practitioners that are in the survivorship space, it might be hard to interpret, hard to know exactly what that means or how they can incorporate that into their recommendations for patients. So Dr. Chaim Moskowitz from MSK published this exciting risk calculator for subsequent breast cancers among females that were exposed to chest radiation. She used survivor data from the CCSS as well as the Dutch Hodgkin late effects and later cohorts. Those were used as part of the validation models. She looked at risk factors, including primary childhood cancer and treatment, hormonal-related risk factors, as well as other risk factors, including family history, obesity, race and ethnicity, as well as previous breast biopsies. And I think it's really interesting to compare the 10-year predicted risk for breast cancer for a 40-year-old survivor with different hypothetical exposures. So the radiation field, whole lung, mantle, mediastinal differentiates predicted risk, as do the combination of radiation therapy and anthracycline exposure, the timing of radiation therapy, and family history of breast cancer. The 10-year predicted risk for a 40-year-old survivor with the greatest treatment and menopause-related risks and a family history of breast cancer is approximately 50%. You can see these two bars. But a survivor with the same radiation field without these risk factors has a 10-year risk prediction that is closer to 10%. So you can kind of see from this group to this group, I think it shows that quantifying patient-specific risks could be highly informative and may help personalize risk and screening based on survivor characteristics, age, and exposure, and may ultimately help us refine screening recommendations and make them more personalized for each survivor. And after our group recently published the largest descriptive study of non-melanoma skin cancer risk and risk factors among childhood cancer survivors, our team at the University of Minnesota, including pediatric dermatologist Dr. Christina Boole, Cindy Im, and myself, along with Dr. Yan Yuan from the University of Alberta, wanted to understand whether we could refine basal cell carcinoma risk prediction for survivors. Notably, basal cell carcinomas represent over half of the subsequent neoplasms that are reported among survivors, with a quarter of survivors actually experiencing not just one basal cell, but multiple. And although these lesions are rarely associated with mortality, they can be associated with significant morbidity, both in terms of aggressive resection, such as Mohs procedures, but also financial and time toxicity to the survivor. And we know that only about 13% of survivors who are treated with radiation report adherence to skin cancer screening guidelines. So what are the current COG long-term follow-up guidelines for non-melanoma skin cancers or basal cell carcinomas? Again, considering any radiation or hematopoietic cell transplantation as the therapeutic exposures of interest, the recommendation is to get yearly dermatologic exams. And note, there's no information as to when these exams should begin or how long they should continue into survivorship. So potentially individuals going in for yearly dermatologic exams from childhood into very late adulthood. So to address this, we developed models predicting subsequent basal cell carcinoma risk by ages 40 and 50 years of age using detailed cancer treatment predictors among survivors from the CCSS using machine learning algorithms. We selected models and that were then validated in the St. Jude Lifetime cohort, where we were able to look at model discrimination and precision. And then we looked at potential reclassification of survivors that were considered to be at risk based on the current COG long-term follow-up guidelines, and then what happened when they were considered in our new risk prediction models at ages 40 and 50. So as shown in the box on the left, by ages 40 and 50 years, the basal cell carcinoma cumulative incidence was 5 and 15% in the CCSS, and 7 and 21% in the St. Jude Lifetime cohort. In the figure on the right, the pie charts categorized survivors into low, so less than 5% risk, as shown by blue, moderate risk, as shown by orange, and high risk, as shown by red. And the risk groups, so you can see these are individuals up in the top who were recommended to have screening based on COG guidelines, based on radiation exposure. And this row of individuals was individuals who were not recommended to undergo screening based on COG guidelines. Using our risk prediction models, we were able to reclassify 37% of survivors that had been recommended for screening that actually would not need screening based on our risk prediction at age 40. And then 29% of survivors that were not recommended screening that were classified as moderate or high risk by age 50 based on our risk prediction. So you can see some reclassification that took place based on these risk prediction models. Here's the screenshot of the risk calculator output from the CCS website. There's both a simplified model calculator that allows input of treatment exposures as yes, no, and then there's also a more detailed model that allows for input of cumulative dose exposures for chemotherapy and radiation. And the output then classifies survivors as low, moderate, or high risk at ages 40 and 50. What we're really hoping to do with this model or with this risk calculator as well as others is bringing them into the clinic and understanding, how in the clinical setting these risk prediction tools are used and viewed by survivorship clinicians as well as survivors, and whether a more personalized approach to screening might improve survivor adherence and satisfaction, as well as accessibility to services. And finally, I wanted to briefly touch on some of the work we've been doing to better understand outcomes after survivors have developed subsequent cancers. There have been several studies reporting on mortality after certain subsequent cancers, including breast cancer, colorectal, and thyroid cancer, but until recently, none had taken into account how subsequent cancer treatment and toxicity had potentially influenced outcomes. So to address this gap, we studied a population of female childhood cancer survivors from the CCSS that developed either in situ or invasive breast cancers prior to 2017. And this was all, part of my career development award, or KO8, several years ago. As you can see on the diagram on the left, survivors with non-carcinoma tumors were excluded, as were survivors who did not consent to have medical record data available. Detailed breast cancer diagnostic, treatment, and toxicity data were abstracted from medical records of 431 female survivors. Survivors were then matched 1-to-1 with females with primary breast cancer from 3 large academic medical centers based on age at breast cancer diagnosis, treatment decade, race and ethnicity, and breast cancer characteristics, including histology stage, HER2, and hormone receptor status. Comparison group data were abstracted in the same manner, so we had treatment data for the breast cancer for both the survivors as well as the de novo breast cancer group, and we were able to identify 344 matched pairs for these analyses. Our initial findings from the work were presented in Nature Communications recently, and when we compared our survivors with subsequent breast cancer to controls and then examined differences in treatments as shown in the figure on the right, and toxicities as shown in the figure on the left, sorry about that, all survivors. And we also were able to compare all survivors and controls to whether they received guideline concordant therapy based on NCCN kind of standard breast cancer treatment guidelines. So you can see that both survivors and controls were equally likely to receive guideline concordant therapy. So although those therapies looked different. So we saw that survivors were less likely to receive cyclophosphamide, were more likely to receive taxanes, were less likely to receive anthracyclines, certainly much less likely to receive radiation, more likely to have mastectomies. All of them fell within the very broad range of what was acceptable for NCCN guidelines. And then when we looked specifically at toxicities, we saw that our survivors were more likely to have a number of different types of toxicities. So hematologic, peripheral neuropathy, gastrointestinal toxicities, as well as cardiac toxicity and dysfunction. So after examining treatment and toxicity differences, we moved on to mortality. And we found that overall survivors have a 3.5-fold increased risk of death after breast cancer compared to controls, as is shown in the panel on the far left, such that at 15 years, the mortality probability in survivors was 41% compared to 14% in controls. And we looked specifically at different histologies. So in situ disease shown here in the middle, you can see that results in a 10-fold increased risk for death comparing survivors who had in situ disease compared to women in the general population with in situ disease. The difference being 39% mortality among the survivors and 2% for controls. And then looking over at the far right, that hazard ratio was about 3-fold greater risk for death among those with invasive disease, comparing survivors to controls. And although we didn't have cause of death for our controls, we were able to take a deeper dive into cause-specific mortality for our survivors. Data are separated out by histology with in situ on the left and invasive breast cancer on the right. Cause of death is shown as being from breast cancer, which is the red shading, and then other causes, which is the blue. So not surprisingly, on the left, you can see with those with in situ disease, much more likely to die from other causes compared to breast cancer. And then on the right, you can see that among those with invasive disease, it was about a 50-50 split of death related to breast cancer versus other causes. And the other causes included other health conditions like other types of secondary cancer, as well as cardiovascular disease. So based on the observed increased mortality risk, we wanted to understand if this might be driven in part by differences in recurrence risk between survivors and controls. And interestingly, as you can see in the figure on the left, risk for recurrence was not different. However, mortality following recurrence was significantly worse among survivors compared to controls. So you can see about a 3-fold higher risk for death following recurrence among survivors compared to controls. And nearly all of the survivors died after experiencing recurrence. Again, we didn't have cause of death data available for the control group, but when we looked at cause of death following recurrence for survivors, we observed 30 among the 48 deaths, 30 breast cancer specific deaths, and then a small proportion of other causes of deaths, with the 10-year breast cancer specific mortality probability of 67% among survivors. So we suspect that the mortality difference between survivors and controls is partly driven by more limited therapeutic options for survivors given their previous exposures to anthracyclines and radiation therapy, as well as their underlying other chronic health conditions, which may further limit their treatment options. So I know I'm getting close to the end of my time. I've been reviewing subsequent neoplasm data for about 14 years. Where are things at? What's changed? My 2-year-old is now 15. She likes to catch real fish instead of the pretend ones in the park. Now has a 12-year-old sister. I'm fortunately no longer a fellow, but still reviewing and validating all of the CCSS subsequent cancer cases and now lead the working group. It's been a really fun opportunity to help shape the direction of subsequent cancer research and hopefully to have an impact on survivors in the future. And as I mentioned, is a good lesson to any trainees. Be careful what you say yes to. And I just wanted to point out that with the expansion of the cohort, there's now, we've gone from just over 2,000 subsequent neoplasms to over 11,000 and counting. With the upcoming data freeze, I expect a couple thousand more added. This is up 8,900 from the 2012 data that we showed. You can see kind of the array of different types. And then nearly 2,400 of the subsequent cancers have accompanying germline tissue and childhood cancer treatment data, and then 728 have tumor tissue. So lots of great opportunities for anyone who might be interested in subsequent cancer research. So summary, subsequent cancer research has progressed from identifying and describing risk and risk factors to really looking at novel risk factors and incorporating them into personalized risk prediction. And our work is now extending to understanding subsequent cancer outcomes and potentially helping to inform subsequent cancer treatments. The number of subsequent cancers among survivors continues to grow, and survivors are aging. And this really does allow us to understand even more in terms of comprehensive analyses and reinforces the need for high quality research. So last bit, our next steps, we submitted a large grant this year that's really focused on a deeper phenotyping of our subsequent malignancies. So through multiple of these more recent studies, we've acknowledged some of the gaps in what we have available in our data set. And so we'd like to abstract detailed biological and molecular tumor characteristics across all subsequent cancer types, as well as subsequent cancer treatment information, and look at standardized outcome data that might help support longitudinal analyses of survival and mortality risk. So our hope is really to develop a first of its kind SMN data set that will support analyses that might help better inform counseling, interventions, and treatment decision-making over time. I'd like to thank all of the folks that have participated and helped with these studies, and I'm happy to take any questions. I'll stop sharing there.
That was fantastic. Wendy?
Thank you so much. No, thank you so much, Lucy. That was really comprehensive, and it was great to see the progression of the research over time. I think that's particularly helpful for our trainees as well. Should we take a couple of questions, Smita?
I think there is a question in the chat box.
Yeah, so
Let-
GI, GYN, and GU cancers aren't prevalent subsequent cancers. Yeah, I think that's really interesting.
I'm sorry, I wasn't I wasn't stalking you guys. I got pulled away for a minute, and then all of a sudden I realized my earbud was talking, and it was you guys, and it was sitting on my desk. It's good to see you, Lucy. I'm gonna leave and stop weirdly stalking your conversations.
No problem. So just looking at this question in the chat. So I think GI cancers, particularly colorectal cancers, we do see a strong association with treatment association, particularly radiation therapy as well as some chemotherapies. The overall number remains smaller than things like breast cancer and thyroid cancer, maybe partly because not as many survivors are getting abdominal directed radiation therapy. It is interesting, the gyne and genitourinary cancers do not seem to be as prevalent, and they must, I suspect, just not have the same treatment-associated risk factors that we see in our more prevalent cancers. We did see, as I was preparing this grant that we submitted, I was actually really struck. We looked at all of the subsequent cancers, even the ones that haven't been frozen yet, and actually did see a relatively impressive number of GU cancers. And so whether that is going to just pan out as being what happens as survivors age, or whether we'll see anything novel, we'll see. But we actually put in for a study on this because over time, it does feel like that number has actually accelerated, and we haven't had a comprehensive report on that group of cancers. But the gynecologic cancers, we really aren't seeing a lot of over time.
Noha?
Hey, Lucy, wonderful presentation. It's always so enjoyable to just listen to you talk. So I just want to touch on something. You mentioned obviously we're moving into trying to identify survivors, and you mentioned the risk calculators for one, like the basal cell carcinoma calculator that comes from your work. Are you how much of the work is being done on the utility of those tools and how they're used, and where is the appropriate touch point, like whether with the patient, whether with provider, how much work is done in that space?
Yeah, that's actually one of the areas we're really looking to get into is more of that implementation and how are these useful in clinic or are they just something that is really fascinating to those of us who do this research? Because, we know that when you're in clinic and seeing survivors, you don't have time to pull out 10 different risk prediction calculators, and survivors don't necessarily care exactly what their percentage is, and neither do providers if they don't know how to interpret that number. And so whether incorporating, we've talked to the folks who run Passport for Care, which is a major kind of survivor app that you can input and get survivor care plans out of to see if it might be valuable there, whether it might be valuable in the EMR to see if you could auto-populate some of those variables into it and then get data out. And then trying to really understand through some of our work with providers if they would even care or use it, even if it were made that easy and that accessible, because I think that's when you look on the CCSS website, there's a whole list of risk prediction calculators, and I think I use a few of them, but I don't know that the rest of my survivorship team does. So I think it's a really good question and something we've been trying to move forward with some of our different grants right now.
Do we have time for more? Anybody else?
Lucie, I'm just wondering if there's a thought about incorporating some of the more classic risk factors into those calculators, like, for example, with the basal cell, history of severe sunburn, skin type, that sort of thing.
Yeah, I think that was our hope initially, is that we might be able to incorporate general population risk factors that are in like the risk calculators for, derm folks. We just don't have the quality of data on those factors, like for sun exposure, tanning beds, that kind of thing, in our cohorts to test it. And so I think we would have to, I agree, it would probably be important and informative. We would have to go back and actually get that data from survivors to be able to incorporate it in a kind of high quality way. But I agree, those would be interesting and important.
Thanks.
Yeah.
Well, Lucie, I think the charges are as follows. We need to somehow integrate or develop studies to integrate risk-based screening for our survivors. A particular topic that has attracted more attention is the hereditary components of it, so pathogenic and likely pathogenic variants, and the risk associated with that, and incorporating that and the clinical factors would be terrific to see if it really has an impact on the outcomes in these patients. So.
Yeah, I agree. I think as a lot of the genetic data are becoming much more accessible, and I anticipate will continue to become more affordable and accessible, those will be really critical factors. So more to come.
Hey, well, thank you I hope it warms up a bit.
Me too. Me too.
Our 44 degrees feeling like 39 is feeling very cold to us. Yeah.
Well, I can appreciate that. But thank you so much for having me today. It was a real pleasure.
Yeah, it was very nice. Thank you so much.
Yeah, thanks. Bye-bye.
Thank you, Lucie.
Bye.